Uh, Candidate 1, can you hear me?
Assalamu alaikum, sir. Yes, sir, I can hear you.
Can you confirm in the chat if you can hear me?
Yes, sir, I will.
Okay, that's fine. So, is candidate 1 with us?
Yes, sir. I'm candidate one.
Okay. So, today is going to be a special session, and this is, of course, base of skull and portion of paranasal sinuses, orbits. My main emphasis will be on base of skull. And this session, I have selected 10 cases, and the aim is to learn anatomy through pathology. And repetition is extremely important. Base of skull is a difficult part of anatomy. So I'm sure by end of this session, you will be masters of base of skull. So we will repeat and repeat and repeat. So let's start with the first case. Slight bit of delay in the software, just hold on for me. Candidate 1, can you see the case?
Yes, I can. The image is very small, sir, if it can be made a bit bigger.
No, it is as big as it can be. Something is wrong at your end. I've got two laptops showing, and it is absolutely fine for me. Uh,
Now it's a bit better. So, yes.
okay, so the point is, can you ask for the mouse if you want to scroll?
Yes, sir. I've requested, sir.
So over to you. Now, this case is a 76-year-old, and it was stroke, rule out stroke. The clinicians actually asked for a CT as well as a CTA. So this is the CT part of it. Over to you.
I've been presented with the CT scan axial section of an adult post-contrast studies, in which I can see. First, I would like to scroll to the whole stack and then.
Okay, just
Uh,
concentrate on the base of skull because of
yes,
time
sir.
factor.
Yes,
And
sir.
uh,
Uh,
but that's good practice what you have told us. Okay.
Yes, sir. So I can see a soft tissue density mass noted in the region of the sphenoid sinus and the posterior nasopharynx, and it seems to involve the base of the skull more so on eroding the base of the skull more so on the right side. It seems to involve the sphenoid bone as well. Um, uh, and it is extending into the nasopharynx posteriorly and extending also in extending upward to involve the like I would like to see the bone window to see its extension into the brain as well as into the orbit as well as into the Pterygopalatine fossa. However, I can see a bit of its extension involving on the left side on the sphenoid wing is definitely involved. So I would like to have the sagittal sections as well as the bone windows to see its complete extension. Now I've been presented with the bone window in which I can see the definite erosion of the sphenoid bone and the temporal, the base of the skull at the level of the middle cranial fossa. I think it's a static single image.
It-
It is just,
Is it not
uh,
scrolling for you? It is not static.
okay, sir. Uh, no, sir, it's not scrolling for me.
Okay, I'll
Maybe I have to, yes, sir. No, sir, it's not scrolling with me.
have you.
Yes, sir, now it's scrolling.
Hmm.
Uh, Sir, it is, uh, sir, definitely it's an aggressive lesion involving the base of the skull and extending on into the pterygopalatine fossa as well as into the sphenoid sinuses and the posterior part of the posterior nares. However, no definite extension into the intracornal region is seen. However, the the medial orbital wall on the right side is thinned out. Uh, so, sir, I believe that this is an aggressive lesion, most probably a carcinoma.
You have said that pterygopalat. Show me its extension into the pterygopalatine fossa.
So, sir, this area, if you can see my, so you see my cursor?
I can see your cursor. Is is this the pterygopalatine fossa?
Sir, it is just posterior to the maxillary sinus region.
Mm-hmm.
Yes, sir. There is involvement of the bone. I am not able to appreciate any
Point out
bones here,
the normal
the base of the skull
pterygopalatine
here.
fossa on the other side. Point it out to me on the other side,
Uh,
on the normal side.
yes, sir. Sir, this one?
Show me the anatomy of pterygopalatine fossa on the normal side. Point it out to me.
Sir, it is on just behind the like maxillary sinus.
No,
I believe
point
this
it
is.
out. Point it out. Talk me, through it. Talk it out through it.
Sir, this part is actually the pterygopalatine fossa on the
Mm-hmm.
normal side.
Mm-hmm.
Yeah, sir. Sir, anteriorly it is anterior to it is actually the maxillary sinus, and medial to it is actually the nasopharynx, and laterally is actually the like the base of the skull.
Base of the skull. What do you mean by
Like I
that?
mean, sir, middle cranial fossa, sir.
Where is the middle cranial fossa here? Point it out to me.
So this sir, I'm not able to remember the exact boundaries like you're asking.
Okay.
Maybe,
So
yeah,
coming back
sir.
to the mass, what do you think is the epicenter of this mass?
Sir, it appears to be in the posterior nasopharynx. It appears to be appearing from the nasopharynx and then eroding into the laterally, then eroding laterally involving the base of the skull on the left side,
When
right
you
side,
use
sorry.
the word base of skull, what does that mean?
Sir, I cannot see the pterygoid plates as well. They are involved on the right side. So these are the right medial and the lateral pterygoid plates on the normal side, and they are also involved on the left side.
Where is the clivus?
Sir, clivus is up, sir. I will just show you. So this is the clivus that is also involved.
So what do you think is the epicenter of the lesion?
Sir, it is in the it is in the clivus, midline in the clivus, posterior at the level of the sphenoid bone.
What is the structure
Some,
anterior to the clivus normally?
sir, sella and sella region, sir. Sir, anteriorly is this.
Where is the sphenoid sinus?
Sir, I am not able. It is like, sir, being involved by the mass.
So what does
This
that
is the
mean?
region of the sphenoid, sir. So it's like a sphenoidal, posteriorly midloin in the sphenoid region involving the clivus and the posterior nasopharynx and extending laterally to
Where is
involve.
the
Uh,
nasopharynx? Show me the nasopharynx.
so this part is actually the posterior part of the nose is actually the nasopharynx. Uh, so this area is the nasopharynx. To be more precise, a bit down. Up is actually the sphenoid
So
part of the
what is your
sphenoid bone.
conclusion?
Sir,
What
I
is the
can
epicenter?
maybe I can show you a bit better in the sagittal view to see the extension and description, sir. And this, sir, this the base, the base of the skull is involved here at the
So
level
what
of
is
the
the epicenter
atlantoaxial
and what
joint,
is
the
your,
dense.
give me your diagnosis. What is your final diagnosis?
Yes, sir, it can be a chordoma at the base of the skull. An aggressive, most probably it's an aggressive lesion. Although I'm not able to see any arcs and rings calcification, but chondrosarcoma can be considered considering the age, uh, and less likely can be. So in post-contrast studies, sir, may I know the age of the patient?
Age is 57.
Yes, yes, sir. So, sir, juvenile angiofibroma cannot be. It enhances more, and it is more in a young person. And Other than that, sir, we can consider malignancy like squamous cell carcinomas or of the sphenoid sinus as well.
Okay, thank you very much.
Yes.
So let me go through on this case. I will do a bit of normal anatomy teaching and then I will uh, go through the case. Each candidate is today going to get a single case. So thank you very much, candidate one. I'll give you the feedback in the after my teaching. So there is no need of waiting, but you can listen.
Yes,
Uh,
sir.
so this is. I'll come back to the case, but this was the sphenoid sinus carcinoma. And the key message here is that in head and neck radiology, epicenter of a lesion is extremely important. What is the epicenter? And from there, you can, even if such a aggressive lesion as it was, you can then sort of infer that what exactly is the origin. And so that is the key. Second point is that develop your anatomy on axials. Of course, nobody is stopping you to ask for sagittals or coronals, but I want you to develop your anatomy on axial. First of all, raise that issue on axial, then confirm it on other sequences. In base of skull, paranasal sinuses, coronal at times is the best sequence, but nobody is stopping the examiners from opening a case like this. And you have to develop your where is the nasopharynx, where is the sphenoid sinus, where is what on an axial. So don't think that they will show you a sagittal, particularly initially. Now, this was a squamous cell. Once you know what is the epicenter, then it becomes quite easy. This kinds of case, and I have selected these kinds of cases today, many of them, where findings are quite obvious, but whole of the viva in the exam will be the grilling of anatomy. What is this? Where is it going? What is happening? That kind of a thing. So it will be a big lesion, but The question answer will be on anatomy. So coming back to the anatomy, we have already covered, uh, last time we have covered temporal bone. So I'm not going to cover it in great detail, but just to make a point that portion of the base of the skull is formed by the temporal bone. Temporal bone has got technically five parts: squamous part, mastoid part, stylomastoid, tympanic part, and the petrous part of tympanic bone. We have covered it in great detail, and this is an important landmark in the base of skull. So today we will take it further. I'll come back to this. Just a quick revision about the cranial nerves, and some of them are important at FRCR level, and because they are, the examiners are going to ask you questions about them. So we know that there are 12 cranial nerves, which are depicted on this diagram. There are two ways to learn the nerves. One way is, if you want, you can take a screenshot of this. Of course, it is freely available on Google also, or any textbook. But cranial numbers are here and which foramen they pass through. So this concept is extremely, extremely important. And I cannot emphasize it more, particularly vis-a-vis base of skull. There is another way to learn the same thing, and that is bony anatomy and what passes through it. So this is the other way to learn the same thing. Now, just these red ones, I just want to read with you. Superior orbital fissure, cranial nerve 3, 4, 5. So this is, 5 means V1 and V2, and then 6 pass through it. Foramen rotundum V2, foramen ovale V3 as mandibular 3. Spinosum, of course, is the middle meningeal artery. Now, this uh, becomes an exam type of a scenario: Vidian canal and jugular foramen. So, Vidian canal is important, and because it is visible on imaging, and I'll show you. And in the exam, they will ask you, where relevant. Vidian artery and Vidian nerve passes through is jugular foramen. We covered it, that the 9, 10, then 11 pass through it. Hypoglossal canal is important for the exam, even for part 1, it's very important. I'll show you the hypoglossal foramen. So these things you have to remember. Now we come to the base of the skull. So base of the skull is made up of 5 bones. Three of them are midline, so single, and two of them are paired. The pair bones include the temporal bone, right and left, and the frontal bones. The single bones anteriorly, this is the ethmoid, this is the sphenoid, and this is the occipital bone. Temporal bone, last time I told you, is the most difficult anatomy of human body is temporal bone. We have covered it. I think the second most difficult anatomy is the sphenoid bone, but much less than the temporal. So these are the midline structures. Now let's tackle them one by one. This is the occipital bone. Occipital bone has got various parts. The point to remember is that clivus is partially formed by the sphenoid bone and partially formed by the occipital bone. So this portion is known as basi-occipit, and the portion of clivus which is formed by the sphenoid bone is known as basi-occipit. I'll come back to this point. Now, other than basi-occipit, this part is known as condylar portion, where there are condyles to, make the joint with atlas, and there are jugular tubercles also. This portion is known as squamous portion. So this jugular tubercle is an important landmark because they will show you, particularly in your part 1 also, and I will teach you today. And this is where, inferior to it passes the what we call the hypoglossal canal. And in the exam also, they will show, they can ask you, particularly when pathology is sitting there. Coming back to the jugular foramen, extremely important foramen. It is not in a bone, but it is in between the petrous temporal bone and the occipital bone. It has got two portions, anteriorly and posteriorly. This is known as pars nervosa and pars vascularis. The ninth nerve passes through it. The 10th and 11th passes through it. Take home point is that 12th nerve does not pass through the jugular foramen. It passes through the hypoglossal canal, which is not visible on this diagram, but I'll show you. On radiology, it is very well seen. So these nerves, 9th, 10th, 11th, and 12th, as soon as they enter the neck, they will go into the carotid sheath. So the 12th nerve also joins it. 12th nerve is an exam nerve. Please remember that. 12th nerve supplies the muscle of tongue and intrinsic as well as extrinsic muscles of tongue. So if 12th nerve is sort of infiltrated or damaged by any pathology, the effect will be on tongue, and they are going to show you that in the exam. And I'll show you a case today actually. Uh, and that concept is known as motor denervation. Motor denervation, and because whenever there is motor denervation, there is some effect on the end organ. In this case, it will be tongue. So we will come back to that. Now, so this was the occipital bone. Quick revision without going into any details. In the petrous temporal bone, we know that there is IAM, where the 7th and 8th nerve pass through it. There will be carotid canal, and the carotid canal is passing here, the carotid artery. This is foramen lacerum. Foramen lacerum per se is not a foramen, but it is filled up with cartilage. So the carotid artery passes over it, which will be known as the lacerum portion of the carotid artery. This part of anatomy is important where my mouse is, my pointer is, and this is the paracellar region. And this is where the cavernous sinus will be sitting. And this is where the cavernous portion of internal carotid artery will go anteriorly. So this portion coming back to the bone is all sphenoid, and here, things, dorsum sella and sella turcica and tuberculum sella, etc. This is the pituitary fossa, all of these things, better seen on a sagittal. This is plenum sphenoidale. Now coming back to the sphenoid bone, we have got a lesser wing, which is this portion, superior and anterior. The lateral and inferior portion, the larger one, is the greater wing of sphenoid. Foramen ovale, this is foramen ovale, where the V3 mandibular division of trigeminal nerve, it passes through it. And this is also an exam foramen, because they will ask you in the exam. This is the foramen spinosum, whether the middle meningeal artery passes. Anteriorly here is the foramen rotundum, where V2, mandibular 2, passes anteriorly. So this foramen here is the optic foramen, and this one is the superior orbital fissure. Now, this concept is important to remember, and the same concept will be seen on imaging, particularly CT scan. So please remember that the optic foramen, where the optic nerve is, it is superior and medial, and slightly inferior and slightly lateral is the superior orbital fissure. Take home point is that superior orbital fissure connects with the intracranial cavity. Optic nerve, optic foramen also connects with the intracranial cavity, but the inferior orbital fissure that connects with the Pterygopalatine fossa. So it is not visible here. So these were the parts of the sphenoid bone. So let's take it further. So these are once again the main nerves which are seen here. So this is the hypoglossal nerve which passes into the hypoglossal canal. This is the jugular foramen. So this is the glossopharyngeal nerve. Posteriorly is the 10th nerve and the 11th nerve. These are the nerves which we have already covered in the IAM, 7th and 8th nerve. So this fifth nerve, three parts go through three foramen, different foramen. So the V1 passes into the superior orbital fissure along with other nerves which will supply the muscles of the globe, orbital muscles. So these are the third nerve, the fourth nerve, the sixth nerve, and the V1. They will pass through the superior orbital fissure. The V2 will pass anteriorly through foramen rotundum, and the V3 will pass inferiorly into the foramen ovale. So these are again shown on this side. This is the olfactory nerve, and on imaging you don't see it like this because there are multiple branches, and they then become on MR or CT. You don't see it like on this diagram. So just concentrate on the pituitary fossa here, the centralmost portion, the busy sphenoid. You can see that this is the busy sphenoid, and here point to remember is that portion of it is the sphenoid bone, portion of it is the occipital bone, and in a growing skeleton there is a synchondrosis in between. And I've seen junior trainees confusing it with a fracture, particularly when you are on call, trauma cases, and people have reported it as a fracture. So don't do that, because in a growing structure, skeleton, you will see this on CT, and you can see the same thing here. This is the spheno-occipital synchondrosis. Take home point is that busy occipit and busy sphenoid. So these are the two words. And key point here is, look at this. Now, and this is clivus. So the pituitary fossa is sitting sort of on top of it. Anterior to that is the sphenoid sinus. And this is the key thing, key concept, or key orientation, which I was asking in the case which we just did. I'll come back to that. Just see here, this is the clivus anteriorly, anterior to this portion. It will be the sphenoid sinus, and then will come the nasopharynx. So this is on a plain X-ray, and all of you know this anatomy: posterior clinoid, anterior clinoid, sella turcica, sphenoid sinus, and please remember that portion of the sphenoid sinus sits below it, and in your exam you will see pituitary macroadenomas extending into the sphenoid sinus. So they will go into the sphenoid sinus. So this orientation is very important. So this is on a CT scan, a bit of repetition. You can see the same thing here. This is the sella and this is the sphenoid sinus. This is the cribriform plate of the ethmoid. The centermost portion, this is the crista galli, where there will be fat, and it's a landmark even on MR. Here you are. On MR, there is fat, so it appears bright signal. And again, the modality changes, anatomy does not. So this is the pituitary gland, this is the clivus, and this is the sphenoid. So the sphenoid sits below the pituitary. Then comes the nasopharynx. Portion of it will be, of course, anterior to the nasopharynx will be anterior to the clivus. But in our case, the epicenter was here. It was all filled up. On the other side, if you see from below upwards, this anatomy is that these are the pterygoid plates. And the pterygoid plates are very important landmark and for your exam, and they will ask you many questions about them. This is the medial pterygoid plate. This is the lateral pterygoid plate. And this communicates with here is what we call the masticator space. Key concept here, uh, in the next sessions, we will come back to the neck, etc. So we will cover it again, but I think we have covered it many times in the past also, that in head and neck radiology of the neck is divided into various fascia because of deep fascia into various spaces. One of the space is masticator space. Masticator, these are the spaces which uh, actually abut the base of the skull. And this concept is extremely important because any pathology sitting in that particular space can go into the cranium. Masticator space is a very important space, both for infective lesions as well as malignancy. So all of this area is masticator space. This previously we used to call it temporal fossa, and this is the infratemporal fossa. These are the pterygoid plates, and the foramen ovale and spinosum is seen here. Other than masticator space, the parotid space, it also abuts the base of skull. Here is the stylomastoid foramen. This is the carotid space where the jugular foramen and the carotid canal is there. And this is the pharyngeal mucosal space where squamous cell carcinomas, etc., they can erode into the skull. Some of these spaces, as they go to the base of skull, become very, very narrow. But the ones which are important are all of these. Pharyngeal mucosal space, this is nasopharyngeal carcinoma. Masticator space, again carcinomas and infections. Parotid space, perineural spread of lesions. Carotid space is extremely important, the jugular foramen space. So once again, here I just want to show you a repetition, but a bit of addition, that this is the cavernous sinus. And you have to have clear-cut ideas that which nerve pass through into the cavernous sinus. So the V1 and V2 of this is the trigeminal. So V1 and V2, V3 will go down, it will dip down. Uh, and then uh, these are the third nerve, fourth nerve, sixth nerve, and this is the superior orbital fissure. This, of course, is the optic nerve. So look at this nerve, the sixth nerve, and it passes anteriorly. This is a portion of the sphenoid bone, actually. It doesn't pass through the temporal bone. And this is the canal which we did cover last time. I'll show you a picture once again. So cavernous, within the cavernous sinus, these are the nerves which pass. And so once again, third nerve, fourth nerve, and then V1 and V2, and then V6. Please remember that the V2, which is the maxillary division, passes through the foramen rotundum. So it is separate route. These ones will pass through the superior orbital fissure. So take home points which will help you to develop your CT anatomy about orbit. Now, these are various bones of the orbit. You don't have to remember many things, but just remember it like this, that this is the optic foramen. You see, it is medial and it is superior. This is the superior orbital fissure. So remember, the most medial most part will be optic foramen and then will be superior orbital fissure. Another key point to remember is that both of these will be in continuity with the intracranial cavity. So this portion, technically speaking, is lesser wing of sphenoid. So the optic foramen actually is in lesser wing of sphenoid. This bone here, the optic strut, is a bone which separates optic foramen from the superior orbital fissure. So this is the superior orbital fissure. And I'll show you on a CT scan. An inferior orbital fissure, this is the inferior orbital fissure which goes, along the lateral wall of the orbit. So this communicates with the pterygopalatine fossa. It doesn't communicate with the middle cranial fossa. So these are the key points to remember. Now, concentrate on this diagram. Uh, on this diagram, we can once again see the fifth nerve here. V1 and V2 pass through the cavernous sinus. V3 goes into the foramen ovale. V2, after passing through the cavernous sinus, passes into the foramen rotundum and goes here, and this is the pterygopalatine fossa, where it produces a ganglion here. And we are going to cover this anatomy, the pterygopalatine fossa. Now, rest of the nerves which are sitting inside the cavernous sinus through the superior orbital fissure, they go into the orbit. Now, it's a very good idea when you learn anatomy, learn it, part by part, small part. So here we are just going to concentrate on uh, on the foramen which are going into the orbit. So just concentrate on that. Don't concentrate on anything else. Now, if you see here, this is the medial most portion. So orientation wise, this is the posterior crinoid. These are the, and this is the optic foramen, right? This is the optic canal, and the foramen will be sitting here. If we go to the next slice, you can see this opening here. Place yourself. This is the middle cranial fossa. This is the sphenoid sinus, and you can see it is going into the orbit. So I go back. This is the optic canal and optic foramen. So this is the superior orbital fissure. And look where we are here. We are at the pterygopalatine fossa. Here, there is a fissure here which partly opens out into the masticator space. So this is in head and neck. It does not communicate with the brain. So remember that. I repeat these three. Optic foramen, what is at this level? At this level, you can see the sella. Slightly inferiorly, now the sphenoid sinus is visible. So this is lateral to the sphenoid sinus, superior orbital fissure. More inferiorly, this is the pterygopalatine fossa. And because the foramen rotundum is communicating with it, and then is the inferior orbital fissure. So on a coronal, uh, let's concentrate on just these three without concentrating on other things. So this is the optic canal, and then slightly more. So this is the optic canal, and this is the superior orbital fissure, which is lateral to the sphenoid sinus. If we go more anteriorly, so this is the inferior orbital fissure, and point to remember is you can see it communicates with the masticator space here. So these are the three foramen. Now we go, now we are going to learn. So till now, what we have learned other than the overview, we have learned the three foramen of the orbit. Now let's learn the foramen rotundum, Vidian canal, ovale, and lacerum on axial, and then coronal. So once again, point to remember is, look at this diagram. Here, this is the ganglion, which is the Gazarian ganglion of the fifth nerve, V1, V2, V3. V1 passes through foramen lacerum, V2 passes through foramen rotundum, and our aim is to learn the anatomy of foramen rotundum. And another thing which passes anteriorly is this thing which I have shown in red here, Vidian nerve with Vidian canal. So Vidian nerve, it goes through this part of bone, and this is known as Vidian canal. And it is a landmark. It can be seen on CT scans and MRs, and pathologies sitting here can go into the cranial cavity through it, and they can go through the cranial cavity posteriorly. So this is the pterygopalatine fossa sitting here. Point to remember is that foramen rotundum, if you see, is slightly more superior than the Vidian canal. So this is a take-home point. Let's see it. So orientation wise, this is the optic foramen, and so the sella is here, and this is the sphenoid sinus. This is the uh, superior orbital fissure. Here you are, superior orbital fissure. Now this is the floor of the sella. The sphenoid sinus is here, and sphenoid sinus is here. Superior orbital fissure is still visible. As we go slightly more inferiorly, you can see this foramen. This foramen is communicating with this portion here, which is the pterygopalatine fossa. Key point is that it is lateral to this sinus. This is the sphenoid sinus. It is lateral. So if I go back, you see superior orbital fissure is superior. Then comes foramen rotundum, and this portion is the intracranial. This is the middle cranial fossa, and this is the pterygopalatine fossa. Now we go more inferiorly, so this is still the foramen rotundum, and this is lateral to the sphenoid sinus. As we go inferior, do you see that the sphenoid sinuses are now more or less finishing? We are at the base of the sphenoid sinus. And here there is this canal, which is the Vidian canal. This is the Vidian canal. And it opens into the pterygopalatine fossa. This is the pterygopalatine fossa, which is posterior to the maxillary sinus. Here, it communicates with the superior meatus of the nasal cavity, and laterally, it communicates with the masticator space. We will come back to this anatomy once again, but I want you to take you back. So here I have gone up, and here we can see this is the optic foramen coming down. Next thing is this foramen, which is the superior orbital fissure. Then we are going, as we go anteriorly, we can see foramen rotundum. And the key landmark anterior to that will be the pterygopalatine fossa. Sphenoid sinus is still there. We are going down inferiorly. And as the sphenoid sinus, we reach the base of the sphenoid sinus, we can see this canal. And this canal is the Vidian canal. So the Vidian canal will be inferior to the sinus, and foramen rotundum will be lateral to it. This is a key point to differentiate. And you can see the pterygopalatine fossa once again anterior to that. So this is the pterygopalatine fossa. Now let's see the same thing on coronal. So this is the coronal, and uh, now these are the sphenoid sinuses, and you can see this Vidian canal, which is just at the base or inferior to the sphenoid sinus. As they go further anteriorly, they actually are just inferior to the sphenoid sinus. These two structures is what I'm talking about. And the foramen rotundum will remain lateral to the sphenoid sinus. So this is extremely important for you to remember. So once again, the Vidian canals will be inferior to the sphenoid sinus, and the foramen rotundum will be lateral to the sphenoid sinus. Quick anatomy review. This is a 3 Tesla MR, so the resolution is extremely high. One key point to remember is the hypoglossal canal. If you see here on a CT scan, it looks it is easy to see, and this is in your part 1 exam they will ask you this, this foramen between this and this is the hypoglossal canal, and you can see on this MR and you can infer that this is the foramen. So this is hypoglossal canal. And of course, this is the jugular foramen. You can see from the medulla, various nerves are passing. Uh, so here you are. I just wanted to highlight that the sixth nerve passes anteriorly into, this is sphenoid bone per se. It passes here anteriorly through it. So last time I showed you a case of Petrus appendicitis. And of course, we know that this is the fifth nerve. This is the the Meckel's cave, yes, and the ganglion which sits there. And of course, the seventh and eighth nerve we have already covered last time. So now an overview of the skull base. And if what we have learned till now, we did learn the overview, and we covered that 3 midline bones are single bones, and 2 bones are paired bones. The temporal bones are paired, the frontal bones are paired, but in the midline is ethmoid bone, which produces the anterior cranial fossa, or a portion of the middlemost portion of the anterior cranial fossa. And then we have got sphenoid bone and we have got occipital bone. So let's orient ourselves. These are the just concentrate on the temporal bone. So this is the temporal bone, mastoid hair cells. This is the petrous apex, and this is still the petrous apex. We can see the internal auditory canal. We can see the internal ear structures, still continuing with the petrous apex, and still there, and then it forms this synchondrosis. This is the petro-occipital fissure, and there is what we call synchondrosis, means that there will be a cartilaginous joint. This is the basi-sphenoid portion of clivus. So a joint is formed there. So as we go further inferiorly, we can see the jugular foramen coming into our view. We can see the carotid canal, the jugular foramen, the jugular foramen. As we go more inferiorly, the jugular foramen, the clivus is there, the jugular foramen is here. This is portion of the petrous temporal bone still visible. We are going further inferiorly, and we have got the clivus sitting here, jugular foramen here, and now we are into this exam canal, which is the hypoglossal canal. You see this thing? Remember this, hypoglossal canal is a landmark. They will show you on axial, they will ask you, what is this? And they will ask you on a chrone. So this is hypoglossal canal. Let's go anteriorly. So, and now the method is to trace it around the sella. So this is the sella, anterior clinoid processes, posterior clinoid processes, and this is the sella, this is the optic canal, uh, and anterior, the dorsum sella comes into play. Point to remember is that this is the pituitary fossa, and inferior to that will be the sphenoid sinus. Inferior to that is the sphenoid sinus, as we are proceeding below. Now, let's see the foramen of the around the sphenoid sinuses. So these superiorly optic foramen, slightly more inferiorly the superior orbital fissure, slightly further inferiorly will be our friend the foramen rotundum, and then posteriorly, uh, here as the so this is the foramen rotundum on this side, and as we the slice passes through the longitudinal axis of the bone, we can see foramen spinosum, sorry, ovale and spinosum. So this is the foramen rotundum on this side, which is not as clearly seen as on the right. If we continue below, this is the sphenoid sinus, and then you will see the Vidian canal coming into view, and now this is the Pterygopalatine fossa. So this is the main anatomy, and other thing which we have to cover is the Pterygopalatine fossa. We'll come back to that. This is the hypoglossal canal, which I was telling you. This is the sagittal sequence. This is the jugular tubercle. See how it looks like. It looks like eagle, isn't it? So this is the beak of the eagle, and this is the jugular foramen, and this is the canal. And they will show you cases in which this is eroded, or they can ask you on anatomy, where is the canal on a coronal. So uh, now this is it. And so this is the canal, and this is the lateral most portion of it on a corona. So let's go to your case now. So in this case, this was a CT. Actually, I did not show you because of time factor, because the clinician had asked for a CT brain and a CTA in one go. They were worried about a stroke. And basically, on the brain part of it, there was nothing. Please remember that today we are, you know, that we are in the world of base of skull, but in the exam world, you have to really make sure that you pick it up. So there is something huge happening here. The candidate did very well, asking for the bone window. Ultimately got the diagnosis also, but a bit of fine touch about anatomy, which I will point it out. Now on post contrast, so this was the post contrast. There was enhancement in it. So I was not interested about that. My whole of my interest was the epicenter and where the lesion and what the lesion is doing. So let's go back up here. So we are at the level of the we are in the suprasellar region. We can see this is the optic foramen. Actually, you can see the optic nerve here also. This is where my mouse is. Let me, yeah. So this is the sella, and these are the posterior clinoid processes. As we go inferiorly, we can see the superior orbital fissure. Here, you can already see something is abnormal. Please remember that inferior to the sella should be the sphenoid sinus. And now you can see that there is soft tissue filling up the sphenoid sinus. And if you see, this wall of the sphenoid sinus is eroded. So as we go inferiorly, of course, look at this. This is the sphenoid sinus, and the wall is eroded. maybe it is communicating with the middle cranial fossa at this point. It's a massive lesion which is sitting here, completely obliterating the sphenoid sinus. Now, posteriorly, if we see the clivus, so anteriorly there is erosion, but if we see more carefully, look how the sphenoid sinus is also expanded. And then there is destruction here. So clearly the epicenter is in the sphenoid sinus. Now, as we go inferiorly, candidate did very well, where pointed out that the lesion is going into the pterygopalatine fossa. But please remember in the exam, uh, they are not going to be satisfied just with this word because they are going to go into details, what is happening. So because everything was destroyed here, the Viva went into a normal, and this will happen in the exam. Many a times they will ask you normal anatomy. So here the anatomy is that you see this is the middle cranial fossa. I go back. This is the optic foramen. So here is the superior orbital fissure. Look at this. This is the middle cranial fossa. Slightly more inferiorly, you can see this another foramen. Here you are. And this is the foramen rotundum. Of course, this portion of bone is completely destroyed here. And there is gross destruction. Now, this is the pterygopalatine fossa on this side. And on the other side, you can see it is completely, eroded or involved by the lesion. Now, as we go inferiorly, so on this side, we can see that these are the pterygoid plates. This is the lateral and this is medial. And this is the maxillary sinus. Here, what is happening that you can see that the maxillary sinus posterior wall is gone, and the plates, they are also eroded, eaten up by the lesion. So it goes here into the maxillary sinus also. So that is a huge tumor, and of course, uh, another point is that let's cover the anatomy of the the pterygopalatine fossa on this case, on the normal side, right? So basically, uh, pterygopalatine fossa is okay. Let me actually show you a sagittal, and I think it will be a good idea to show it to you on a normal case so that now on sagittal, which I never showed the candidate, you can see what is happening. And it is completely eroding. This is the sphenoid sinus. There should be air sitting here. It is completely eroding. The epicenter is there. And this is the portion of clivus. So the basi-sphenoid portion is eroded. Basi-occiput is there. Of course, portion of the tumor goes into the nasopharynx, but portion of the nasopharynx is still. This is the hard palate, so all of this is partially the nasopharynx. So the epicenter is in the sphenoid sinus. And of course, I did not show the candidate the coronal, but just to make a point that you can see how it is causing erosion, and this is the middle cranial fossa. So, candidate one, well done. You got the diagnosis ultimately. Just a bit of fine touch of anatomy is, what is required. Now, let me show you a normal case. So, our aim here will be to learn the anatomy of the pterygopalatine fossa. Pterygopalatine fossa is a landmark or a junction in head and neck radiology. what happens is that there is a fossa here which we are going to describe. Medially, it communicates with the nasal cavity. So this is the fossa where I am pointing out. The pterygoid plates are here. This is the maxillary sinus. And look at this space. This is the space we are talking about. Now, medially, it communicates. Uh, Actually, there is a bit of mucous membrane, etc., in a living person there, but some nerves, etc., go there. This is the palatine fissure. Sorry, sphenopalatine foramen. This communicates with the superior meatus of the nasal bone. I repeat, sphenopalatine foramen. But it is covered by mucous membrane, etc., in a living person. So pathology from the nasal cavity can go here. And this is why they show you the case of juvenile nasopharyngeal, uh, angiofibroma, sorry, which is an exam case. And it actually occurs in the nasal cavity, passes into the pterygopalatine fossa. So one take-home point is that sphenopalatine fissure is foramen is the foramen in between the nasal cavity and this fossa. Laterally, you can see it is open. And where is it opening? It is opening into the masticator space. This is the nasopharyngeal masticator space. So this is known as the lateral pterygopalatine fissure. Now, as far as intracranial cavity is concerned, it has got two connections, and we have already covered. One of the connections, if you see here, this is it, and one of the connections is the foramen rotundum. And another connection, slightly more inferiorly, is the Vidian canal, And they will show you cases in on a coronal and axial, you will see expansion of the Vidian canal. Anteriorly, please remember that the pterygopalatine fossa communicates with the orbit through inferior orbital fissure. So let medially with the nasal cavity, laterally with the masticator space, posteriorly through the foramen rotundum and Vidian canal with the middle cranial fossa, anteriorly with the orbit through the inferior orbital fissure. But the but is that it doesn't stop there because technically it also communicates with the oral cavity. And if we trace it downward, so these are the pterygoid plates. If we trace it, do you see this small structure? This is the greater palatine canal, and you will see it will open. Where it opens? Into the oral cavity. And there are nerves and arteries, which palatine nerves and artery which passes through it. So it is a pure junction in head and neck radiology. And because of this, tumors, infections, etc., can go intracranially, etc. And what is sitting here? Remember, next to the foramen rotundum, what is sitting there? Cavernous sinus. So if there is infection which goes inside, it will produce cavernous sinus thrombosis. So, so that is why it is a very, very important junction or landmark. Let me show you sagittal first of all. So this is a sagittal, right? Let me make it slightly smaller. Do you see? This is the maxillary sinus. Now you will see it beautifully. Here you are. You see this? This is the pterygopalatine fossa. This is the pterygopalatine fossa and how it communicates with the orbit, etc. So this is the pterygopalatine fossa. And I will show you the coronal. Here, our aim is to see the foramen rotundum and the Vidian canal. So the sphenoid sinus is the landmark. This is the sphenoid sinus. You can see this right and left, there is canal. And this is inferior to it. So this has to be the Vidian canal. And you will see, just let's trace it. So here you are, it opens into the middle cranial fossa. As I'm tracing it anteriorly, look at this. It comes, and then opens into this space. Do you see this? So even on coronal, you can see it. This is the pterygopalatine fossa. Going back, lateral to that will be this foramen, and this is foramen rotundum. And you can see how it opens here. So this is foramen rotundum, and this is Vidian, and both of these are for the exam. They will ask you and ask you anatomy if they show you this case. Okay, so candidate two, are you with us? So, the teaching was basically the anatomy teaching I had designed for, I think, mainly on the case one. And now you are going to apply your anatomy on all other cases, and there are 9 cases to go. So let's now change gears and go to candidate. By the way, this is just to make a point. This was the MR. This is a post-contrast MR of that sphenoid sinus. So I'm not just for your interest, I'm showing you. One key point to remember is that in head and neck radiology, you must remember your sequences. The key sequences in head and neck radiology are T1 and stir. So we used stir and T1, right? Stir will be by definition fat saturated. T1 is a beautiful sequence because of fat. It shows us so many things, particularly, in tongue carcinoma, etc. At times, you see it without contrast much better than post contrast because of fat. So, T1 is a very, very good sequence in head and neck. But when you do contrast, you must do fat saturated. This is a key thing here. Absolutely critical. In intracranial pathologies, it's not mandatory. At places when skull is involved, base of skull is involved, you must do it, but it's not mandatory. But here it is mandatory. So this is a post contrast, and my experience is that many students they don't remember this protocol. So I repeat: T1 and stir, fat sat, fat sat, pre-contrast, then post-contrast fat set. So these are the key sequences. Here you can see the same thing, and you can see the same tumor and how it is enhancing and doing everything. Another concept which I wanted to highlight, and this will be relevant for your day-to-day practice also, that this is a territory base of skull where there will be complementary and supplementary role of CT and MR. And don't, in your clinical practice, don't be shy to use them like this. Because MR at times will show you things which CT will not be using. And please remember that there will be cases in which you will pick up something on MR and you will ask CT to correlate it. So at times it's a two modality which we use. Okay, candidate two, are you with us?
Yes, hello, sir.
Okay, candidate two, this is a 76-year-old female, and once again, stroke. And they did a CT and CTA. Over to you. So just can you ask for the mouse?
Yeah, sure.
So the mouse is with you.
Okay, this is CT axial brain of patient with history of stroke. I will take a moment to scroll through the images. before I come for a conclusion of my findings. Okay, so I can see that there is a soft tissue mass centered on the right side of the base of skull with extensive bone erosions. It's okay, as I can see that there is erosion of the right apex of Petrus bone and the pterygoid plates. It's extending up to the posterior to the sphenoid sinus. Okay, there is invasion of the clivus on the right side.
So, madam, do you want to see the bone window?
Yeah, please.
Here you are.
Okay. Okay, so there is extensive erosion. Sorry, I cannot scroll. Yeah, okay. Okay, so there is again extensive erosion of the
Show me the epicenter. What do you think is the epicenter of the lesion?
the right side. It's the right side of the sphenoid busy clivus, busy occiput, sorry, and the clivus
Where is the
extending,
Petrus apex?
and
Compare.
the Petrus apex also. It's invading the right Petrus apex. Um, mm, mm, okay, but yeah, here. There is destruction of the right squamous squamous temporal bone,
Okay,
and
one
yeah,
second.
uh,
Hold on, please. Hold on.
okay.
Same case with contrast. Over to you.
Okay, so this is the CT of brain with contrast. Okay, so I can see the there is a heterogeneous enhancement of the mass.
I want and I want you to sum it up. Tell me what can it be?
Okay. So the epicenter of the mass, I believe that it's involving the nasopharynx, um, and with the obliteration of a fossa Miller on the right side, and um, I'm trying to delineate the carotid artery and jugular vein are not involved. Um,
So just conclude the case, please. See the
okay. Okay, there is an extension into the right cavernous sinus with enhancement and encasement of carotid artery. And there is a destruction of the carotid, the anterior portion of carotid canal. So in summary, this is an aggressive lesion, likely neoplastic lesion. Um,
So, madam,
so okay, so my differential could be nasopharyngeal carcinoma.
okay, thank you.
Okay, thank you.
So this is a chondrosarcoma of the Petrus apex. Of course, one can consider other differentials also. Now, as far as Petrus apex lesions are concerned, there are quite a few, and chondrosarcoma is one of them. Chondrosarcomas, the jugular foramen is also sitting next to it. So it can also extend into the jugular foramen. Please remember that there are many synchondroses in the base of skull, and chondrosarcomas can arise from many. And that is why it is also in your Chapman, it is given under clivus lesions also, because key point here is that chondrosarcomas tend to be para-midline and chordoma is midline. So this is the key point to remember. Our case, as the candidate very well picked up, also extended into the cavernous sinus, and this is a differential diagnosis in CNS, cavernous sinus, or paracellular mass, and where chondrosarcoma is given that it can go, which is common sense, where it can go. So let's go back to the case. Now, so it was a good idea to ask for a bone window after initial description, because the bone window will show this to you in a much better way. But on brain, rest of the changes were chronic changes, and you can see that something is happening. Now, as soon as you see it and you go for a bone window, try to compare it right and left. And the symmetry is your savior. So we are coming here. This is Petrus apex. And please remember that at times in Petrus apex, there will be aeration, which can happen as we are going slightly inferiorly. You can already see that this Petrus apex is there. This is the carotid canal, and there is a large lesion sitting here. Please remember, it arises from the synchondrosis, the joint between the two. So how it is eroding the clivus, and this is the center, and it is slightly off center. It is slightly off center. A chordoma, will be more midline. This is slightly more. You can see a bit of calcification. If I change the window for you, you will see a bit of calcification in the lesion. So that is, what happens in a chondrosarcoma. Uh, Slightly off midline, and you call it. So the idea in head and neck is that because of this epicenter, you will say that this is it. On this if I go into the nasopharynx, I don't see it. But if you say that in my differential or nasopharyngeal carcinoma, I will take it. I will still take it. Having said that, this calcification also goes in favor of chondrosarcoma. Now, on this contrast, actually, this patient was also a stroke patient. So they asked for CTA also because of the clinical. Now, this is do you see these longus coeli muscles? And this is invading inside into them. But if you say that in differential diagnosis, I'll keep nasopharyngeal carcinoma, fine, it's fine. But then it goes superiorly. And here you can see how it invades the cavernous sinus and goes into the cavernous sinus. And you can see that from here, the cavernous sinus is sitting up here. So I did not show the candidate, the corona, but just to make a point that this is the tumor and how it is going superiorly. So the main idea is the lesion was okay, fine, easy. But then the thought process which you have to develop is that what is the epicenter? And this is where the differential, give some words to it. You might pass if you say that this is a malignant lesion, malignant looking lesion with here, but to get more marks, you have to be more elaborative. Thank you very much. Well done. So candidate 2 is done. Let's go to candidate 3, 4. Just let me make other candidates co-host. Just 1 second. 5. Okay, let's go to the candidate 3. Are you with us?
Yes, good evening, sir.
Good evening. Okay, so this patient, actually, let me just, because of time factor, I'll show one sequence myself and then I'll hand you over. This was interesting presentation. This is a 71-year-old. The ENT asked for, the patient has got tinnitus left, classical. So they did an IAM scan. This was the IAM, and IAM was normal. There were some sequences which in our protocol we do in addition. It's not a classical brain, so I'll show you one of them, and which is this one. Over to you.
Okay, so I'm provided with flare eggshell sequences of the brain. So I'm okay, yes, now I'm able to. Yeah. So this patient has presented with tinnitus.
So are you doing it intentionally? What's happening? Your voice is
the images are scrolling very fast.
okay. Let me scroll for you. Leave it. You leave it.
Yes,
Right.
sir.
So I am scrolling for you.
Yes. So looking at the images, I noticed that I'm not able to appreciate any significant pathology in these.
Madam, look at base of skull. Hint.
Okay. So, in the base of skull, I noticed that on the left side, um, so I would like to see the T2 weighted images if available.
Have you picked up anything? Any suspicion of anything?
Sir, on the left side, in the region of internal acoustic meatus, there is some hyperintensity I noted.
Internal acoustic meatus.
Yes.
You asked for a T2, I'm giving you a T2. This is a T2.
Okay, so I'm provided the T2 weighted images, eggshell cuts. Um, um,
You know, the flare maybe was better. So this is my hint for you. So I've gone back to the flare, right?
yes, sir.
Just concentrate on base of skull.
So, so I'm not able to pick any significant pathology. Are the CT images available for the patients? Probably.
Let me once again go to a T2. But as I was telling you that flare was actually better than this T2. So you have not picked up anything?
I'm not able to see any significant pathology. If the CT images are available, probably I will be able to comment on the CT scans.
I'll give you a last try on these flare sequences. Let me tell you, I'll scroll for you once again. Then I ask the chat. Anybody has got anything? Anybody, please participate. Chat. Left. Excellent. So let me take over. Fine. Thank you, candidate three. Uh, you see, in this case, the if you see this flare sequence has been done with fat saturation at places it is at times you will not see it with fat saturation. Now, if you see here, you have to develop your eyes. This is the skull. This is the skull. As we go inferiorly, now look at this. There is something which has gone into the skull. This is the greater wing of sphenoid, and so there is some high signal in the skull. And this thing, I am going into the idea to show it to you was to develop your, what happens. This is the masticator space. So actually, there is an elephant sitting there. If you compare this side with this side, one can argue that there might be some artifacts initially, but if you look carefully, look at this. This thing here is the mandible, and actually you can see high signal in the mandible. These are the muscles of mastication, and you can see that in muscles of mastication there is high signal. The parotid gland, look at this. This is the parotid gland, which is posterior to the mandible. And this high signal goes there also. It goes into the deep lobe as well as uh, and this is classical, infratemporal fossa, the what we call the uh, nasopharyngeal masticator space. So from there, anatomy is that this goes and touches the base of skull. Now, there is a lesion which is infiltrating. It is transspatial. Transspatial means it is going into the masticator space, it is going into the bone, it is going into the parotid gland, and then it goes into not only the mandible but also the sphenoid bone. So what it is. And so I would have then shown you this post contrast sequence here. This is so just to make a point that then this is on a stir sequence. You can see how it is behaving, and then it is going again the same thing which we have already learned. If we give contrast, it will enhance. And so it is enhancing. You can see these vascular channels. And you can ask for a CT scan just to confirm it. And on a CT scan, you will actually pick up phleboliths. And look here, how many phleboliths are there? You see this? Now look at the anatomy. Look at these phleboliths. And so it will be transspatial, going from one space to other. So if I show you the bone window, here you are. The infiltration into the bone will not be as clearly seen as on MR, but one can argue here. Look, compare this with this one. Please remember that intramuscular hemangiomas of limbs, they also come in the exam. And I have shown you cases in MSK world, intramuscular hemangioma. And key point is that they behave in an infiltrative way. They go into the bone. And that doesn't mean that this is a benign, sorry, this is a malignant lesion. And now the new classification is that instead of hemangioma, we call it vascular malformations, and there is more to it. But if you call hemangioma, fine, confirm it with a CT scan. So they will come in MSK world, they will come. I am showing you a base of skull case, but part of it was the anatomy and the concepts of what it does. Okay, thank you, candidate 3. Candidate 4.
Yes, sir.
Candidate 4. So this patient is a 77-year-old, and initially we had another CT which the patient had really moved. So we then recalled the patient, did another CT. The point is that this is 77-year-old. The patient has got headache, loss of smell, epistaxis. So initially a CT head was done. Over to you.
I am provided with the non-contrast CT brain images of the 70-year-old male, in which I can appreciate the senile cerebral atrophic changes and hypoattenuating areas in the bilateral frontal lobes. There is soft tissue intensity. DN is seen in the right posterior ethmoid sinus. Which is causing thinning of the bones and attenuation, soft tissue attenuation material also seen in the bilateral frontal sinuses, and there seems extension of mass into the interior cranial fossa, which is causing compression over both cerebellar hemispheres and producing cytotoxic edema in the both frontal lobes and subtle compression over the frontal horns of both lateral ventricles. I would like to see the coronal and bone window to confirm my findings and the extension of the disease.
You want to see what?
Coronal bone window.
Coronal bone window.
Yes.
Here you are. The patient is not, not cooperative, so it is quite rotated type of skull.
Yes.
If you want, I can show you the axial once again.
Okay.
Just a second. You want to see the axial because this will not
Yes, sir. Yes, sir.
Okay, this is the axial. Over to you.
Sir, it is not scrolling now.
So let me scroll it for you. So I'll go down. Now I'm coming up.
Sir, again, there is a redemonstration of soft tissue intensity lesion in the sinuses, which is involving the right maxillary, right ethmoid, and bilateral frontal sinuses. I want to see any erosion of the bones.
Mhm.
In the
Right.
cribriform area, right cribriform plate seems eroded,
Okay. Very good.
and both frontal sinuses right frontal sinuses mainly opacified with this mass.
So what we did was that we did an MR. So I'm showing you an MR.
Okay, sir. This is a flare images.
You want me to scroll for you?
Yes, sir.
So I'm going superiorly. I'm going all the way till the top. I'm coming back now.
Okay. There is marked vasogenic edema in the both frontal lobes, and I think there is erosion of the cribriform plate on the right side, and this mass is extending into interior cranial cavity, which is causing this edema. Rest of the brain shows atrophic changes and small lacunar impacts in both sides.
What
So,
we will
in conclusion, it's an aggressive lesion which is arising from the nasopharynx crossing the cribriform plate and causing compression over both cerebral hemispheres and edema. It's likely it can be a seizure neuroblastoma or any other malignant mass which is arising from the sinus, which is extending into the anterior cranial cavity and causing this.
to see anything else.
So, can you scroll it?
No, what I meant was that will you make your diagnosis just on this flare sequence? Would you like to see any other sequence?
Sir, I would like to see the post-contrast images. This mass is markedly enhancing and entering into the anterior cranial fossa with meningeal thickening.
Okay, so your final conclusion?
Esthesioneuroblastoma.
Excellent, well done. Good.
Thank you.
So now let me take you through this. Olfactory neuroblastoma, or whatever you want to call it. And this is what it is. It is a rare, slow-growing malignant tumor arising from of olfactory neuroepithelium in the roof of the nasal cavity. Usually it will be dumbbell shape, but dumbbell shape means that, there will be a constriction and portion which goes into the intracranial cavity, and there will be a portion which is sitting in the nasal cavity. And the portion which goes into the intracranial cavity will can enhance like anything. One of the thing is that a peritumoral cyst at the margins of intracranial component is characteristic. Two peaks, young adults, middle age, tend to occur after treatment. So our case was 77 years, but it was in the second age bracket. So this is from Radiopedia. These cases are also from Radiopedia. This diagram is also from Radiopedia. And you can see that, from these nerves, it will arise. Portion of it will be here. Portion of it will go superiorly into the intracranial cavity. Look at the CT scan, how from the ethmoid sinus, it is going into the intracranial cavity. This is another case from Radiopedia where you see this lesion, sort of just like our case where there was a lot of edema and how it is enhancing. So let me go through the case. Now, so on usual window, actually, retrospectively speaking, if you see there was, this low density, if you see there is a bit of high density here, right? Look at the sinus. There is a bit of high density, which might be because of chronic changes, but there is a bit of high density. And as we go, the candidate did very well that picked up this lesion here. And you can see in the nasal cavity how it is causing expansion of the medial wall. So something is sitting there. Actually, what is happening is that portion of it is not very clearly visualized, but as we go superiorly, we can see something happening here. And then it goes and then it vanishes. So the candidate asked for a bone window where this is the lesion. And as we go superiorly, you see, this is the lesion. And here, uh, candidate pointed out that there is a bit of erosion, which was very well done. Actually, what is happening is that there is, the frontoethmoid recess is compressed, and that is why there is secondary sort of sinusitis type of picture. So and with passage of time, this might become a mucocele actually. So if you see here, uh, you can see this erosion here. And you can imagine that the frontoethmoid recess will be here. And actually, if I go to the brain window, you can see that something is sitting there, right? So in any case, on MR, there was very significant edema. And anatomy was the key here. You know what is happening, how it is going from here, even on this flare. One point is that when in your exam, when think what you do in your day-to-day practice, you will never make a diagnosis just on the basis of non-enhanced scan, which is on a flare. You will always do a contrast, ask for it. So this is the lesion. And here, where I am pointing out, are there any cysts? Yes, there are. Do you see these cysts? Yes, there are. If I go back to the flare, here you are, this low signal, confirm it on a T2 weighted sequence. And what did you read? You read that, in the intracranial component, peritumoral cysts are characteristic, is the word which is used. So this is the lesion. And you can see how it communicates with the nasal cavity and then goes here. On an axial, actually, you can see everything. And on post contrast, how it enhances. And if I show you a sagittal, you will see it very well. Here you are. You see how it is enhancing. So this is olfactory uh, neuroblastoma. Okay, well done. Candidate, next candidate 5.
Hello. Hello,
Yes.
sir. Good
Candidate,
evening.
are you with us?
Yes, sir. Can you
Okay.
hear me?
Yes, we can hear you. And this, you can ask for mouse. I'll tell you the history.
Sir, I think if you show me case, then I can ask for mouse because, okay.
Okay, so this is a 72-year-old patient with previous right-sided stroke.
Sir, I couldn't see the case. Sorry, sir. I couldn't see the case.
Okay, just 1 second. Now you can see.
Sir, first, can I ask a request? Now I can request you remote control.
Okay, so in this case, this is a 72-year-old previous stroke, and now this, the patient has come from overseas actually, now has presented, and they are worried about a recurrent stroke. What I'm telling you is that there is a stroke here, and this is an old stroke. Over to you. Anything else?
Okay, these are non-enhanced CT head axial sections of 70-year-old patient came from overseas with history of previous stroke. I'm scrolling from top to bottom. I can appreciate that there is old infarct um, involving the right frontal region, frontoparietal region top. Um, Now I'm going down. Okay, yeah, right over here. Yeah, just scroll. So yeah, right over here, I can appreciate that there is isodense extra-axial lesion in the left, on the left side, in the vicinity of the temporal fossa.
Madam, excuse me, can you hear me? Can
Yes,
you?
sir.
There is nothing
Yes,
on
sir.
there is nothing on left side. Concentrate on the right.
Okay. Okay. Sorry. Yeah. Okay. I can appreciate that there is a low density area involving the right temporal region, right over here. Yeah. In the paracavernous location and extending and invading the right temporal lobe.
Madam, excuse me. This is you see, in the exam, you don't do this. You don't point out lesions, you speak what you are saying. You don't like it unless it is needed. You cannot do this, that I am looking at this and you point out that this is the lesion. You describe it. Over to you. Don't use your mouse unless it is needed or it is asked. Over to you.
Okay, there is a solid cum cystic lesion involving the right temporal region. It shows internal foci of calcifications, and I am sorry. Yeah, and it is extending into the. It is somewhat extending into the basal cistern. There is surrounding mass effect in the underlying temporal lobe. It is in close proximity to the right middle cerebral artery, and also there is also involvement of the right-sided cavernous sinus. So I am Also, again, going down, there is another lesion involving in the region of the right um, um, petrotemporal region, in the region of the um, um, in the posterior cranial fossa vestibule. There is also lesion is extending into the Petrus apex, and this is extra axial. It shows internal regions of high density. So I am suspecting some neurofibroma or schwannomas. So I will further uh, confirm my findings on the post-contrast imaging. And also I would like to see this on the bone window. Okay, in this bone window, there is destruction in the region of the Petrus apex, and there is also involvement of of the.
Why are you look at more, look where the scan takes you. You're just using it as a static image.
Okay, sorry. Yeah, its epicenter seems to be at the region of the Petrus apex, and it is aggressive lesion. It is destroying the bones in right over here in the region of the Petrus apex, and there is invasion of the right side of the clivus, and also somewhat basis sphenoid. I am looking, there is also a tiny foci of calcifications are also there. I think the carotid canal is also involved by this lesion, and foramen lastrum is also involved.
I have given you a post contrast.
Okay, on the post-contrast imaging, there is enhancement of this lesion, which is going into the posterior cranial fossa and is causing mass effect on the cerebellum and also the
Tell
brainstem.
me your diagnosis. Tell me your diagnosis.
Sir, on the findings along the right parasagittal location, this and with calcifications, aggressive lesion, it could be chondrosarcoma. Other differentials in this case would be metastasis or chordoma is less likely because this is off the midline. Other differential less likely could be some neurogenic tumors like schwannoma.
I am scrolling for you.
Okay, these are FLAIR images. Again, there is an aggressive lesion appearing slightly iso to slightly hypointense on the extraaxial on the FLAIR images with internal areas of low intensity in it. It is also extending into the sphenoid sinus and also into the I think the nasal cavity. Sorry, in the posterior nasopharynx. It is also extending along the posterior nasopharynx. There is also a secondary involvement of the automastitis due to this pressure effects on this mass lesion. So, so this is, I think, this is neurofibromas.
Okay, thank you. Thank you. Okay, this is an absolute brilliant case to learn your anatomy and everything. So let me take you through it. Now, the patient had a stroke and previously. So this is that stroke. As we come here, we can see this mass which is extending on the right side Sorry, I think my screen is, you cannot see my screen. So this is the first CT on which we can see that there is that old infarction. We can see that there is a large mass. This mass involves the middle cranial fossa, the temporal lobe extends here. Actually, you can see how it extends superiorly. Now, as we trace it inferiorly, so whole of this is the mass. What is the anatomy here? That this is the cavernous sinus, and you can see that it is invading the cavernous sinus. Now, at this point, actually, portion of the mass passes posteriorly. This is the pons, and we can see it extends into the cerebropontine angle. Maybe a portion of it goes into the IAM. There is another lobulation here. Now, at this point, we can see that the mass actually, even on this window, this is the common carotid artery. So this is the common carotid artery, and we can see that the mass goes inferiorly. And here, anatomy-wise, the jugular foramen, etc., is totally involved. And this is even on this window, I'll show you the bone window. You can see that this is the hypoglossal canal. It is invading it. Now, portion of it goes, into the carotid canal and then posteriorly, while there is a tongue of mass which goes anteriorly. Now, if you see carefully, this is the sphenoid, sorry, the adenoids, and there is a tongue there which goes into the nasopharynx, and then it goes inferiorly. Now, on this, if you see your anatomy, what is happening is that uh, if you go here and compare this versus this, there is a lot of destruction, and you can see that, as I was pointing out, that the hypoglossal canal, etc., is involved. On this CT, we can see if we uh, go here, we can see the superior most extension of the mass, and then the same thing which I pointed out already. Here, what is happening? Now, this is the carotid sheet on this side, and this is the jugular foramen. And you can see that the jugular foramen is completely destroyed and encased. And where is the carotid artery? Actually, you don't see it. And maybe this was a reason why the patient had a stroke previously. This mass must be sitting there since ever. And you can see how it goes. This is the region of I'll show you a coronal. This is the hypoglossal canal. And you can see the tongue of mass extending here. And then it is extending inferiorly. Key thing is, exam finding is this. Anybody in the chat, what is this? What is happening to the tongue? Can you answer it in the chat? Anybody? What is happening to the tongue? Denervation. Excellent. So this is motor denervation. I'll come back to this point. So what is happening, that the 12th nerve is gone. And that is why there is denervation. And then we go to here. If you go to the coronal sequence, which is this one, we can see, look at the anatomy, you look for that eagle. Now, this is the eagle. Mr. Eagle is sitting here, and this is the beak, right? This is the normal side. So this is the hypoglossal foramen and then the canal, and this is the eagle. Where is the eagle? Gone, destroyed. And in the exam, I'll ask you this. I'll show you a coronal, and I'll ask you that what is happening to the jugular tubercle. Where is it? What is happening? So you have to tell me that this is. If I go to post contrast, you can see this mass here. So this is a jugular foramen mass also indirectly. And this is how it behaves on post contrast. But I will like to show you a bit of anatomy on this cis sequence, which is, and you can see even on this cis sequence how it is going all the way superiorly, extending all the way here, right? And as we come down, the carotid artery, this is the normal side, and how it is going into the cavernous sinus, and it is destroying the Petrus apex, tongue going posteriorly, tongue going into the jugular foramen, and tongue going here inferiorly. And this is this is the hypoglossal foramen, where it is, completely destroying. So this is a brilliant case to learn so many things. So this was actually a nasopharyngeal carcinoma. The epicenter, of course, will be debatable, but in nasopharyngeal carcinomas, they can do this kind of behavior where they go, anteriorly, posteriorly, intracranially. And just to make a point about nasopharyngeal carcinoma, right? So this is pharyngeal mucosal space, motor denervation of the hypoglossal nerve. And please remember that this has come in the exam and expected, because what happens is that in this particular case, you can see changes in the T1. There is low signal here, stir, slightly high signal, patchy enhancement. So in this particular case, uh, uh, in motor denervation, they will show you a case where tongue will be visible. And the concept is that when there is motor denervation, initially the muscles show edema. So they are high in signal intensity on stir sequence and can show enhancement. In a subacute form, the edema subsides, and there will be fatty replacement. So there will be patchy enhancement, just like our case here. And in chronic, it will just become fatty atrophy. So, and this thing can happen in other parts of the body, by the way, the motor denervation. This is another case where we can see this fatty atrophy of the tongue on right side. Whenever you get this kind of a case, you in your clinical practice or in your exam, you have to ask for a MR or a CT going back to the base of the skull, because there might be a lesion at the jugular foramen which is causing this. So that is the catch here. And if you don't find anything, then we call it idiopathic hypoglossal atrophy. This is, of course, different patients. This is just like our case, fatty atrophy. This one has got stir. So this is a good case where we can learn many things from this case. Okay, now we go to the next candidate. Next candidate.
Yes, good evening.
Good evening. So this one is a 17-month-old baby, fever, headache, very unwell patient, red eye. Over to you.
Okay, I am requesting the control.
Yes.
So, I have been provided with the CT scan as I am trying to scroll. CT scan axial section with contrast of a baby who presented with a red eye. I can appreciate that there is an ovoid shaped area of increased density that is noted on the medial aspect of the right orbit and it is causing lateral deviation of the right medial rectus muscle. There is mild proptosis of the right eye as compared to left side, as well as there is mild preseptal soft tissue thickening and enhancement noted. I'm looking on the rest of the images. The left orbit appears unremarkable. There is also opacification of the right ethmoid cells. The optic nerves, the optic nerve appears to be mildly displaced. The right optic nerve appears to be mildly displaced. The superior ophthalmic vein on both sides appear unremarkable. The cavernous sinus shows there is the cavernous sinus actually shows comparable signals on both sides. I would like to see the bone window images and based on these findings, okay. My diagnosis is a subperiosteal abscess involving the right orbit, as well as
So subperiosteal abscess of what?
I can also see the opacification of the right ethmoid as well as the sorry, I think I changed the window.
Okay, leave it. I'll set it for you. Over to you. So
Yes, yes.
my question is subperiosteal abscess of what?
A right intraconal. No, it's not intraconal, intraorbital. Because it is causing displacement of the medial rectus muscle, so it is outside the muscle, outside the cone.
So what do you mean subperiosteal abscess? Subperiosteal abscess has to be for a particular part of bone. My question is very
Yes,
quick.
yes.
Of what?
Ethmoidal.
Okay, thank you.
Right.
So this is a classical exam case where let me show you a picture before. Now, this is the concept of conal, extraconal, intraconal optic nerve sheet, and extraocular myositis usually due to sinusitis with orbital cellulitis, fat and muscle infiltration, enhancement, subperiosteal abscess. So now this picture tells you what happens when basically you will see and opacification of the ethmoid sinus. This is the lamina papracia, which is a very thin bone, and subperiosteal abscess will sit here within the, as the name tells you, subperiosteum. Of course, the inflammatory phlegmon will go and into the orbit. It can cause myositis, which will be enhancement of the muscle, enhancement of the fat. In this particular case, look here. If you look carefully, this is the medial rectus, and you can see another opacity here. And this opacity is because of this subperiosteal abscess. And depending on the scenario, you should ask for post contrast, and you can ask for MR if the symptoms are because you have to rule out intracranial extension. Classical exam cases, most popular exam cases in head and neck are uh, infections and complications of infections. So in this particular case, on post contrast, you can see that there is extension into these meninges, and then there is edema. Okay, well done. So let me show you the case. So, so first of all, on bone window, we can see this opacification. Look at this is the ethmoid sinus. Look at this ethmoid sinus, which is opacified. Lamina propria is such a thin bone that at times you can convince yourself that there are erosions. So, but having said that, in this particular case, one can argue that something is happening there, and you can see something is happening there. Ask for contrast, or now there is an inflammatory phlegmon which is sitting here. Look at the medial rectus. One can argue that it is thick and it is also enhancing. So this now you can see the bony defect very well where I am pointing out, and there is pre-septal extension, etc. So description wise, you have to be more elaborative for the examiner to give you full marks. Of course, this is the same thing on coronal, and we can see some small locules, so as if there is a bit of necrosis sitting here, and this is that abscess part. It's an absolute emergency, and these types of patients, if you are in a center where they do it, they might do surgery. They might not wait because optic nerve compression and things like that. In your pertinent negatives, etc., the candidate did very well. We are pointed out about the cavernous sinus, and cavernous sinus was normal. But one of the pertinent negatives should be that as we go posteriorly, of course, I did not show coronal, but this is the optic nerve, so you can say that it is abutted, but it is not compressed, or in other case, if it is compressed, call it. So they consider it absolute emergency. Okay, well done. Next is uh, who's the next candidate? Are you with us?
Good evening, sir.
Good evening. So this patient has got a history of breast CA. The patient is a 76-year-old diplopia bilateral, and she has history of iodine. So initially a CT was done without contrast. Uh, Anything which you can pick up on this case?
Okay. These are plain CT head and neck images of a patient who is a known case of breast malignancy. I will try to give it a scroll and we'll start commenting then. So in this sections, I have observed that there is bilateral intraorbital extracornal soft tissue density masses are seen in the region of lateral rectus muscles. The belly of the both lateral rectus muscles are swollen, but there is normal tendinous insertion. Sir, I would like to see the coronal images. Rest of the brain parenchyma, I would just like to give it a scroll.
Don't worry about it. As far as what we call rest of the parenchyma is concerned, it was normal. Just one second.
Okay.
Just one.
Sorry.
So
Okay.
just one second, madam. Let me give you a better corona.
So should I start?
No. I want to give you a better coronal actually. Yeah.
Okay, so these are the zoomed up coronal views of the same patient. I would like to go again to the orbital region, but somehow my mouse is stuck.
Let me take you there.
Okay, okay. So in this coronal imaging, there is again redemonstration of the same finding. Bilateral lateral rectus muscles are swollen, and there is also I have observed something in the lacrimal gland region. Yes, the lacrimal gland region on the right side is also a bit enlarged as compared to the left one. And I've also observed that the contralateral lacrimal gland is normal, and there is somewhat thickening of the inferior part in the inferior part. I'm trying to appreciate whether it is inferior rectus muscle. Inferior rectus muscle is normal. There's just some inflammatory stranding seen in the periorbital region within the
Madam,
lobe.
can you hear me?
Yes, sir.
Okay, you have done very well. What is your conclusion?
Sir, my conclusion is that I'm worried about two things. One, it is that likely thyroid-related orbital disease. I'm calling it thyroid-related because the myotendinous junction is not involved. But the lacrimal gland is enlarged. I would like to take a history if the patient is known case of sarcoidosis. If I would like to give a chest X-ray review. If not, then I will like to, as it is already a known case, it can be a metastasis, it can be a lymphoinfiltrative disorder. So I will like to discuss it in MDT, this lacrimal gland involvement.
Okay, you did very well, and then you went off tangent. And did you hear my history, by the way?
It was a known case of breast malignancy and some thyroid-related disease.
Thyroid-related disease, I never said that. I never said that. So, okay, let me take over. You did very well, but in the conclusion, now the point is that this case has got involvement of the muscle. And this muscle, and by the way, in thyroid related disease, there is a pattern of involvement, which is inferior rectus and lateral rectus and things like that. In this case, there are what we call very well picked up on this axial, where we can see this. And of course, when we saw the coronal, these were in the rectus. So these were bilateral findings, and only portion of the belly was involved. So when the history has been provided, uh, what else can it be? So the point is that this was uh, this is the differential diagnosis. This is the differential diagnosis of the orbital conal lesions, as in the muscles. And by the way, thyroid associated orbit, typically bilateral symmetrical muscle involvement, inferior rectus, then medial rectus, then superior rectus, then lateral, and then so all of this. But metastasis is there. Sarcoidosis and lymphoproliferative will always be, but most commonly from breast. And this patient was, of course, a breast CA. So, in your thought process should be related to what the examiner has pointed out, and the history is critical. That they will never misguide you or something. When they provide something, you have to really grasp to that. And this is it, and on MR where we can see actually this is, sorry, this is not post contrast. I wanted to show you a post contrast. So this is a post contrast where you can see this enhancement, etc. But I think even on a non-enhanced CT, we can give the same diagnosis. Okay, thank you. Next, please.
Hello, Assalamu alaikum, sir.
So this case is uh, is 72-year-old presented with headache.
Hello, sir. Can you listen me?
Ask,
Hello.
you
Hello,
know,
Assalamu alaikum, sir.
so
Yes, sir. I asked for control.
just go to the base of skull.
Okay, sir.
Before you begin, it's an announcement for everybody that next Thursday, Dr. Radhika Prasad, she is coming over as a guest to conduct a Viva. You might be knowing her. She works with Dr. John Curtis. So she's in her team. So next Thursday, she is going to take a Viva. She will take a teaching type of Viva, which will be feedback after every case. We will take 4 candidates. And this is for next Thursday. Okay, then, please, over to you.
Sir, I am provided with axial MR images, T2-weighted MR images, in which there is a pacification or T2-weighted hyperintense signals noted in left-sided mastoid air cells, and complete opacification of mastoid air cells is noted, and multiple T2-weighted hypointense areas are also noted in the region, and there is erosion of the middle cranial. Uh, uh, there is erosion of the Petrus apex and interior mastoid air cells, and I can appreciate intraaxial extension of the cilium as well into the left-sided temporal fossa. However, no definite involvement of the temporal lobe. I would like to see the post-contrast images of the patient if available to look for enhancement. I cannot appreciate any further abnormality in the rest of the brain parenchyma, including cerebellum or bilateral internal auditory meatai are normal.
The patient had a CT actually next day.
Okay. So the mastoid air cells, there is mild left-sided mastoiditis, mild to moderate, and I can see an enhancing mass in the region of the left maxillary sinus, which is causing marked. So let me scroll through the images. I can appreciate a moderately enhancing mass in the region of the left maxillary sinus, which is causing erosion and destruction of the posterior and medial wall of the maxillary sinus, involving the left parapharyngeal space, causing destruction of the left pterygomaxillary fissure, extension into the infratemporal fossa, and medially this lesion is causing destruction of the medial wall of the maxillary sinus and extension into the nasal cavities. And I'm so now I am again scrolling through the images. So there is erosion of the hard palate, and anterior nasal cavities are normal.
Okay, what is your conclusion?
Sir, this is an aggressive lesion, which is having an epicenter in the left maxillary sinus and in the nasal cavity, extending posteriorly to involve the left parapharyngeal region, infratemporal fossa, and causing erosion of marked erosion and destruction of the adjacent bones. So this can be a case of keeping in view the advanced age. The differential for this include squamous cell carcinoma of the maxillary sinus, and this. Hello.
Is going into the intracranial cavity.
Sir, on these images, the intracranial structures are not visualized. I can only see the upper part of the nasal cavity.
Okay, thank you. Thank you. You know, there has been a pattern today which I want to highlight, that when I give you a next sequence, you have to scroll through it before you make your diagnosis. You So I can see in quite a few people today that when you go to the next one, you don't scroll. You have to scroll up and down. So this case is a case of carcinoma of the left medullary sinus, which was well picked up. The only thing is the viva is on the extension of the lesion. Now, so here, uh, this is the T2 weighted sequence. We can see this low signal here. So a portion of it is fluid, which is in the medullary sinus. Now it goes posteriorly into the muscles of mastication. Now here, if you compare it, this is the medullary sinus, so the tumor is going infiltrating posteriorly. Now here comes a bit of fine touch because this is the middle cranial fossa, part of the temporal lobe, and you can see that this is the temporal lobe, and actually even on this axial, the tumor is sitting inside. So at least one can raise that issue that it is born into the intracranial cavity, the middle cranial fossa. Now, same thing on on CT rather. So then we did a CT scan, and on CT scan, uh, this is the post contrast, and on this post contrast, the point is that you have to scroll up and down to be able to pick up everything. Now, even here, one can argue that on an axial slice, you see this is the heart palate which is eroded. So I would have been very impressed if that was mentioned. It is skewed here, and this is the enhancing lesion, and this is the masticator space, and here it goes into the cranial cavity. So this is the temporal lobe sitting here. And even without a bone window, one can see that it has gone inside. And of course, it is going into the Pterygopalatine fossa is completely involved. Of course, it has gone into this coronal. Even here, actually at the edge of we can see it. Uh, so it is going into the cranial cavity. So here you are. So this was picked up, which was fine. But posteriorly, whole of this exercise is about what else is involved, things like that. Okay, overall you did well. Okay, thank you. And second last case of the day. So this is a 17-year-old uh, who presented with epistaxis. Over to you. Is the candidate with us?
Yes, sir.
Yes.
Sir, I have requested remote control.
Okay, I've given you the remote control.
Okay. Sir, I am looking at the CT scan images, coronal sections of a patient who presented with epistaxis, and I could appreciate that there is a soft tissue density mass projecting into the nasal cavity, the left half of the nasal cavity. Sir, I could appreciate the mass going into the Pterygopalatine fossa and extending in the left infratemporal fossa as well. So can I have a look at the axial images first?
Here you are.
Thank you, sir. Sir, on the axial images, yeah, now they are scrolling well. I could appreciate that the left pterygopalatine fossa is significantly dilated with mass seen over here. I could appreciate the mass extending into the nasal cavity as well. I want to look at the foramen rotundum. Yeah, the foramen rotundum is also widened.
Where can you point out the foramen rotundum?
Yes, sir. Sure. Sir, this one is the normal side and this
is the abnormal side.
Is it?
Yes, sir. So I think so. This is the pterygopalatine fossa. The mass is extending through pterygomaxillary fissure, and infratemporal fossa, it is also extending into the
Can you show me?
nasal cavity.
Can you show me the foramen rotundum on the
Yes,
abnormal?
sir.
Where is it?
Okay, sir. Just give me 1 second. So this one. This is the normal, and this is the abnormal widened one.
Let me give you a coronal sequence.
Okay, sir.
Show me the foramen rotundum
Okay, sir.
or anything else you want to show me.
Okay, sir. Okay, so this is the mass on the left, and I'm looking for the. So I think this was the foramen rotundum.
So is it involved?
No, sir. It
So
seems to be on axial images, but it's not.
yeah, okay. So what is your conclusion?
Sir, I want to look at the post-contrast images. However, on this window, considering a mass centered and the history, I'm thinking of angiofibroma, nasal angiofibroma, but I would like to confirm it on the.
Okay.
Yeah, sir, I could appreciate the mass centered in the pterygopalatine fossa, causing the bowing of the posterior wall of maxillary sinus anteriorly with extension into the nasal cavity, and yeah, it's reaching up to pterygomaxillary fissure, but not in the infratemporal fossa. So, considering the imaging appearance and intense enhancement, I'm thinking of nasal angiofibroma as my first differential. Yeah, it's the primary differential I have.
Okay, thank you.
Thank you, sir.
So the only thing is anatomy, and in anatomy you have to be very careful what you are pointing out, and you know, when this kind of a scenario with a 17-year-old with epistaxis is a giveaway. So if you see, this is the optic nerve and this is the superior orbital fissure, and then this is the middle cranial fossa. So at places when there is angulation is not clear, sometimes in some cases you will actually struggle to see the foramen rotundum very well because of the angulation of the scan. So you should ask for a coronal. And on this coronal, you can see that, just wait, the software is hanging actually. Okay, so if you see here, this is the foramen rotundum, and it is absolutely normal. The key finding is, the distinction finding is that this is the Vedian canal, and this Vedian canal versus this Vedian canal. So the tumor actually has gone into the Vedian canal. And this is what this case was about. Other than the diagnosis, the fine touch was this, and this is the pterygopalatine fossa. The candidate did well. We are asked for contrast, and even here, the same finding is visible, which is here you are. This is it, and you can see this enhancement which goes in. So this is nasopharyngeal angiofibroma with extension into the, of course, you will see cases which will go into the intracranial cavity, etc., etc. And so the same thing here, where we can see one thing is that I just forgot to describe the findings here. So let me describe for everybody. There is a mass there, mass in the nasal cavity. Please remember that this is in the superior meatus. Now, this is the Sphenopalatine foramen. So the mass goes here, sits in the pterygopalatine fossa. This is the masticator space. It does not extend into the masticator space. It causes this anterior bowing of the maxillary sinus. And in 30 years ago, when they used to diagnose these things on plain films, on a lateral PNS view, this was a sign where the lateral wall of the sinus, we used to call it a sail sign. So and of course, the Vidian canal bit of it will always be better seen on the coronal scan, as I have shown you. So this was classical nasopharyngeal angiofibroma. Okay, last case. Thank you. Last case of the day.
Yes, good evening, sir.
Okay, good evening. And this case is 40-year-old. Patient has nasal blockage, severe headache, known case of sinusitis, now has developed a swelling in the frontal region. So just one second. Let me give you axial initially. So this is the axial for you. Over to you.
Okay, this is axial CT bone window for a 40-year-old male presented with nasal blockage. Okay. I will scroll. Sorry, doctor. I think I have a problem in scrolling. I can't scroll. No, it's scrolling now. Okay. Okay, I can see that there is mucosal thickening seen in the frontal sinuses, left frontal sinus, and ethmoid, left ethmoid as well, and also the left maxillary sinus with hypertrophy of the inferior turbinate on the right side, and there is some sort of nasal septum deviation. I can't see any bone destruction. The lamina papricia appear normal, and the wall of the maxillary sinuses appear normal. Okay, so this appear for me as a chronic sinusitis in the involving the frontal and ethmoid and the left maxillary sinus with no bone affection. Doctor, sorry, could you scroll for me? I can't scroll well.
Yeah. So what?
Yeah, the sphenoid sinus appears is spared, and no other mucosal thickening in the nasopharynx or the nose. The mastoid air cells appear aerated bilaterally.
So, madam.
Yeah.
What do you think is here? You know, I told you.
Yeah. Sorry, doctor.
You know, I told you the history of the patient. The patient, other than very acutely unwell, has got a swelling frontal.
Okay. Okay, so this is a frontal swelling appear as a soft tissue swelling over the frontal. Yeah, it appears slightly hyperdense. This may be subperiosteal abscess due to the inflammation in the frontal sinuses. This is my diagnosis, Potts-Puffy disease.
What will you do?
I would like to do a check with contrast to confirm the diagnosis.
Actually, what we did was that we did an MR actually.
Okay.
This is the flare sequence.
Okay, this is flare sequence, sagittal, axial flare sequence for the same patient. I can see that there is soft tissue, high intensity soft tissue appear in the front, anterior to the frontal bone. Is there any contrast study for the MRI?
Yeah, I'll show you contrast. This is contrast.
Okay.
So I'm
Yes, there is mucosal enhancement seen in the left maxillary sinus and the frontal sinuses, with peripheral enhancement of this lesion. I think this might be abscess. My diagnosis is abscess due to frontal sinus, and I think there is also meningeal enhancement under the frontal sinus.
any other sequence you want to see?
Can I see the sagittal cuts? Yeah. Okay. Yeah. So yes, I think this is an abscess in the front, anterior to the frontal bone, due to sinusitis of the frontal sinus, with meningeal enhancement and also involvement of the anterior frontal parenchyma. Yeah. Okay, this is diffusion.
Contrast coronal.
Sorry, this is contrast coronal. Okay. Okay, doctor, I see that there is epidural enhancement as well. This collection here.
Anything else you would like to see?
Is there diffusion?
This is the diffusion.
Okay, there is diffusion restriction noted in the frontal lesion and also in the maxillary sinus, and confirms the presence of abscess, and there is also parenchymal diffusion restriction. Okay, which I didn't appreciate it before, so I would like to check it also in the flare. And I would like to check in the ADC, if it's a true restriction or not.
Conclusion. Give me your conclusion.
So I think this is an frontal sinusitis with subperiosteal abscess and intracranial abscesses as well.
Where are the intracranial abscesses?
In the and in the left occipital and parietal region.
What do you mean region? Is it
Uh,
intraparenchymal? Is it extraparenchymal?
yeah, there's involvement of both. There's a the subdural, epidural abscess, and intraparenchymal as well.
Thank you. So, uh, now this was a absolutely classical 2B case, and I was very helpful to point out to the swelling again and again. And but in the exam, they might not do it because I did tell that there is a swelling initially. So you have to listen to everything. Some of you missed the diagnosis in case 8, and this was a maxillary sinus carcinoma, juvenile angiofibroma in case 9. Now, case 10. This is frontal sinusitis with brain abscesses. These are epidural abscesses, actually. So this is Potts Puffy tumor this is the picture. All of these are different cases. This is a different case, this different case from Google. Usually they say that they occur in children, but can occur in adults also. Just like subperiosteal abscess can be in relation to the ethmoid sinus. Similarly, it can happen in relation to the frontal sinus also. And so the patient will present with hard swelling. That is the key. And so in this particular case, there is subperiosteal abscess, intracranial abscess. And the same thing was there in our case. So now we go to our explanation, and that will end the day. So if you go back, the points to learn in this case are that we picked up the sinus and there was a swelling. One can ask for another window to if we see anything, and the examiner might show you a CT with contrast, uh, which was asked, I believe, but of course we did MR in this case, which is fine. But please remember the learning point in this case is that your pertinent negative or positive will be, is there a breach or dehiscence of the bone? That is very critical. And the take home point here is that on a CT scan, you might not pick up or see any dehiscence. And even then, there can be a subperiosteal, what we call abscess. So on the flare sequence, this is the flare, sorry, where is the flare? This is the flare sequence. We can see this is the sinus and we can see this it. Now, candidate did well. We're asked for a post contrast. Now on this, one thing which I forgot to show you on flare sequence. Actually, if you see here, something is happening here. You know, a sulcus, which is, and this is a exam point, where a sulcus has got high signal. You know, on a CSF, sulcal high signal means problem, either subarachnoid hemorrhage or leptomeningeal processes and things like that. So this should have been picked up. Now, if you look carefully, look at and this is a classical exam case. So this is a beautiful finding, which the examiner will spend all the time on this flare sequence with you. Compare these sulci with these sulci, and you will see that how it is attenuated, means something is happening there. Then you see this high signal, and then you see some high signal here frontal. And then you have already picked up that there is sinusitis, and of course, there is something happening in the bone. So, sorry, in the frontal region, as in the skull. Now, on this post contrast, this abscess is fine, that is dusted. There is some enhancement which was picked up. And if you look carefully, something is happening here. but on other sequences it was here. One feels that there is something happening, and this is the same region where there was abnormality on the flare sequence. Now, if you look carefully, look at the leptomeningeal, look here versus these, and you will agree that there is more enhancement on this side. So that is another subtle finding which is visible. Then I showed a sagittal, which the candidate asked, and here it is very clear that this is an epidural abscess. This is an epidural abscess. It's just not meningeal enhancement, it's more than that. Now, other than that, I showed intentionally a coronal, where part of the funding was picked up and part of it was, I think, not mentioned. So part of the funding which was picked up on, so this is that abscess where, so this is the subcutaneous part, this is that abscess. Now, if you see, look at this dura, and this dura is showing enhancement. And there is some element of enhancement here. So something is happening there and something is happening here. And if we go now, here you are. Actually, you can see, I think this was picked up by the candidate. Epidural. So the word epidural or extradural was, I think, not coming to the mind. So this is it is going all the way posteriorly. Dural venous sinus. Look at the dural venous sinus. Look at this filling defect. What does it tell you? Means it is thrombose. So here comes 1 mark. So I would have given you 1 mark just for this finding. Just to show you, let's go back to the previous sequence. I did not show you a T2, but develop your eyes on a T2 where you can see normally there is a signal void. From tomorrow, start looking at the T2 in your day-to-day reporting coronal, and you will see a signal void. Of course, I did not show it to the candidate, but just for teaching, I'm telling you that this signal void is lost. So, and on post contrast, it was very obvious. So something is happening here. You remember we saw a bit of enhancement there, and something is happening here also. Actually, now you can see this focus where I am pointing out fluid containing, but the diffusion in this case was absolutely brilliant on diffusion, but whole of my viva will be on flare, I warn you. Flare is the key for the exam because the findings are subtle, but you have to pick up. Now, now you can see what is happening, that there is, abscess, this is all epidural or extradural abscess. Here at 2 places, it is extending into the parenchyma also. But rest of it is sitting, along the transverse sinus. And here, this is the component which we saw on the sagittal post contrast. You remember the flare where something was here. So it's a very, very good case where there are signs of pot puffy tumor itself is a very rare thing, particularly in the developed world. Very rare. But it can happen. And it was an adult. I think this was a 40-year-old. Usually it's children. And then these subtle findings where everything is checked. So this is the kind of case, this is a classical 2B case, which it was. This patient was, they did burr hole. They did burr hole from here. And we have got many post-op scans for this patient. More, it went from initially, sorry, you see the burr hole. This is post burr hole, by the way. You can see this burr hole, and you can see that how the abscess now has increased. So initially the patient went from bad to worse, and then of course recovered. So now you can see on a CT scan. So develop your eyes, forget about the burr hole. but develop your eyes on, these are slightly more advanced findings, but you can see this epidural abscess here. You can see this epidural here. You can see this, and this is of course parenchyma. And if we see the edema part, you remember what I was showing you on flare sequence. Look at these sulci. Look how they are effaced, and you see this enhancement. So there is a bit of leptomeningeal enhancement also. So this is a good case, classical exam case. Okay, candidate, this was candidate 10, isn't it? Well done. Well done.
Thank you, doctor. Thank you.
Okay, co-host, if you can share the what we call the feedback form, please. So well done, everybody. I hope you learn anatomy. That was the key today. And tomorrow when you go through your anatomy on a few cases, open CT, paranasal sinuses, etc., and go through it. There is no shortcut except for repetition, 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 axial and coronal. Co-host, if you can, yeah, that's fine. Now we can see it clearly. So that was it. Next session, as I've told you, is going to be a Viva session by Dr. Radhika Prasad. So don't miss it. It will be quite special. And in August, I think we have got quite a few sessions which will be interesting. And by the way, the last session of, don't miss it, I tell you, 28th of August session is being done by Dr. Kath Halliday, the president of RCR. Kath is a pediatric consultant. So her niche area is suspected physical abuse. Suspected physical abuse previously was known as NAI. Now we call it suspected physical abuse. So she will give you a lecture also on this, and then another faculty member will show you cases on same, FRCR cases on. So don't miss that. That is on 28th of August. There are few other teachers who are coming in August. Keep looking for that. If As far as head and neck is concerned, what I have covered till now include the temporal bone. I think I covered it in 2 sessions, if I'm not wrong. And then today was base of skull. My main emphasis, other than FRCR cases, is anatomy, anatomy, anatomy. So now you have covered the most difficult anatomy, which is temporal and the base of skull. And I think next time also, whenever my session is, I might show you random cases. They will be more interesting, which will be neck, um, suprahyoid and infrahyoid neck, as well as the oral cavity. So that I will show. So see you on next Thursday. Not my session, as I've already told you. I'm in a bit of a hurry, so I don't want to take questions, but one or two I can. Anything anybody wants to ask? Yeah, I'm fine now. I'm fine. Thank you very much for asking. So last Thursday I went, it was quite, should I say, urgent that I went unwell. So absolutely fine now. Thank you for asking. Okay, then I think I will go satisfied today. I think you have mastered the anatomy and there are no questions. So hope to see you on next Thursday. Thank you.